Good afternoon, everybody, and welcome again to another edition of the virtual meetings that the New York State chapter of HIMSS is putting on. Today's session will be discussing Modern Medicine Needs Modern Technology, a clinical discussion. Next slide, please. For those of us that are out there, we will keep the Q&A line open, so if you have any questions, please type them in. We have somebody who is monitoring that line for us, and we'll be able to feed them to our moderator, who will then be able to present those questions to our panelists. For those that need live captioning, press the CC button, and you'll be able to have the video control, and you'll be able to read what's going on. If you run into any technical difficulties, just click on the refresh and you'll be able to come back in your browser and it'll come back up again. As we have done with all our other events, this will be recorded and will be available as soon as possible on both our website and our YouTube channel. So make sure you go out to our YouTube channel to take a look at some of the other recordings that we've put in the past. Next slide, please. And again, our commercial here is come and join our chapter. Become a member of HIMSS. Click on the site or take the QR code. Come and join us. Be part of our chapter. We're doing a lot of exciting things. We'd like you to have anybody that's involved in healthcare to be part of our chapter. Next slide, please. And it would be remiss if I didn't talk about our upcoming events and upcoming elections. For those of us that are members right now in good standing, before the 31st of this month, please register. The emails have been going out to everybody. If you don't have it, you can come out to us and let us know, and we'll get the information to you. The actual voting will take place starting June 7th. And it'll end on the 18th of June. We've got some great candidates. Also, if you go out to our YouTube page, you'll see the candidates because we recorded them with a couple of questions to see that are these the right folks that you would like to have part of the board membership for the New York chapter. We also have committees that are open. So if anybody's interested in joining and spending time in our committees, please write to either myself or to Nick Cristiano, and we'll be more than happy to direct you to the right committee chair and get you involved. Next slide, please. Thanks to our sponsor for today, helping us to put this on, Zebra Healthcare. Take a look at the slide here. If anybody is interested in getting some additional information, Lonnie Helfand is listed with his email address and phone number. Go out and take a look. Give him a call. I'm sure he'd be more than happy to be able to chat with you about what they can do for you and your organization. Next slide. All right, let's get started with the event. Our moderator is Rikki Jennings. She's the Chief Nursing Informatics Officer at Zebra Technologies. Rikki, it's all yours. Let's have some fun.
Thanks, Tony. And thanks for having us here today. I'm honored to share this panel discussion with all of you and with the individuals you see up here on the screen. I'm excited to introduce you to them. Our first panelist is Kay Lytle. Kay is the Chief Nursing Information Officer for Duke University Health System. She has 28 years of experience in clinical informatics, including a wide variety of applications ranging from small departmental systems to large health system EHRs. Kate also teaches part-time for Duke University School of Nursing in their health informatics program. She's a certified professional in healthcare information and management systems and a fellow in HIMSS. Okay, thanks for joining us here today. Our second panelist is MaryAnn Connor. MaryAnn is Memorial Sloan Kettering Cancer Center's Director of Nursing Informatics. MaryAnn is an executive nursing leader executing center-wide strategies which leverage innovative technology to advance the efficiency and accuracy of clinician practice. MaryAnn leads a team of board-certified advanced practice nurse informaticists and technical specialists translating evidence-based clinical practice to intuitive, pioneering, and safe technology solutions. She is an established adjunct professor at New York University, active member of HIMSS and AMIA, and co-chair of New York HIMSS Nursing Committee. MaryAnn is board certified in nursing informatics and a certified professional in health information management systems, and a fellow in the American Medical Informatics Association. Thank you, MaryAnn, for joining us today. And our final panelist joining us is Nancy Warren. Nancy is the Associate Vice President of Clinical Informatics for Corporate Information Systems at Northwell Health, responsible for the implementation, integration, and optimization of EMRs and innovative technologies across the system. The Corporate Clinical Informatics Department has increased adoption of various EMRs and innovative technologies by nursing across Northwell Health. The clinical informatics team is dedicated to decreasing the EMR documentation burden on nursing and implementing innovative mobile technologies to improve the quality of nursing care by increasing the time nurses spend at the patient's bedside. Nancy's nursing background includes over 15 years as a pediatric ICU nurse, 5 years in nursing management, and over 15 years of experience in various nursing informatics roles. Nancy, thank you for joining us today and sharing your expertise as well. So what do you say we get started here? Let's start this discussion. We are eager to engage with all of you today. The world's pandemic response spurred a rapid amount of innovation across every business. In healthcare, as our clinicians responded to the increasing needs and surge in patient volumes, patient care models were challenged and new ways of working evolved seemingly really overnight. Multi-year plans and roadmaps were condensed into sometimes even just a matter of weeks. And in our dialogue here today, we are looking to this incredible panel of experts. We're going to discuss how both technologists and clinicians can leverage today's experiences in preparation for the future. So MaryAnn, I'd actually like to start with you today. From your perspective, at the onset of response, what were your priorities in the new models of care? What were some of the challenges you faced, and how have the solutions you developed during that time influenced your organization's priorities moving forward?
Thank you, Rikki. I really, first of all, thank you very much for asking me to be on the panel today with these esteemed experts. I look forward to sharing some of our experiences. One of the main things when the pandemic occurred that we realized very quickly, and I think as nurses we do, was the impact to how we would deliver care, knowing that the risk involved ensuring safe patient care, but also protection for the clinicians who needed to take care of the patients. A couple of things that we quickly put in place were ways to have the nurses be able to see the patients and communicate with the patients as remote as possible. One of the examples I'd like to share initially was looking at ways for us to communicate from the inpatient perspective how a patient's status of COVID. One of the things that we were able to do very quickly was take our alarm management system, which we had already put in place, and I think was a very important project which provided nurses with mobile tools at the point of care to take care of patients on telemetry, and use that same technology to map very quickly critical lab alerts, which were our COVID positive alerts, to the patient flow command center and to our infectious disease team as soon as the results came in. And that allowed us to alert the right person at the right time to ensure movement of patients quickly to the right locations, which would be isolation, and also ensure safety for the clinical teams that were taking care of these patients. That was one example of taking current technology, bringing a team together, and our teams together, our nurse informaticists, along with our technical teams and our lab team and infectious disease teams, and come together and say, how can we brainstorm? How can we turn this around within days to ensure that we're safely taking care of the patients, but also taking care of the clinicians caring for the patients? I think everyone clearly knows that nursing were at the forefront. They stayed at the forefront. So did nursing informatics. because we're nurses, and we believed that we needed to partner with our clinical teams and ensure that they had the tools that they needed. A second example using that same alarm management system was the need to increase the ability to alert our respiratory therapists. We all needed to increase our ventilator beds and our ICU beds. And with that came the risk of ensuring that patients who were on beds were being cared for as quickly as possible. We use that same technology to map vent alarms to respiratory therapists and to those nurses caring for those patients. And those are two examples about communication, collaboration, and using mobile technology that we quickly put in place at MSK.
MaryAnn, routine, there's so many elements of that just kind of catch me off guard as a clinician, and the power of working together. And I think we'll see that's a recurring theme as we go through each of our conversations here today. Nancy, can I ask you, how were priorities similar or maybe even different at your organization? How clinicians were involved in setting those priorities?
Yeah, hi. I'm so happy to be here today. So during the initial pandemic surge, we had to very, very quickly surge from over 3,000 beds to over 5,000 beds, as well as bringing in clinicians to cover that. And for communication with patients that were isolated in COVID, we put anything and anything out there, anything and everything. We had tablets, we had Echo, Amazon pads. We kind of, just to get by and to support the staff during that initial surge, it was kind of, a little bit of a free for all. So as we started to go down in numbers, they put together 12 recovery work stream groups across Northwell. And this was to look at what we did during the pandemic initially, not only to prepare for potential resurge in the fall, but also for how we would address a lot of things in healthcare going forward and how it would change our life. One of these work groups was called Clinical Communications and Support. Because what really came out right from the beginning was communication was the key factor that staff needed. So partnering with Maureen White, who's the chief nurse exec for Northwell, and my CNIO, Sue Robertson, they reached out to the CNOs and went to the bedside staff. And they went to the nurses, and the question they gave them was, what could you have used? What did you need that you did not have that would have helped in your care? And an array of technologies came out, but top and foremost was had just started our mobile journey, but we did not have mobile devices for nursing. And the number one thing came out was that mobile devices for nursing, for communication, just across the care teams, not even talking about the patients and the patients communicating home, but that communication across the care team was key and was identified early on.
Wow, it's a simple question. What did you need? And then look at the process. And I imagine you've got a long road up. You made significant headway already, but a long road map ahead. And how exciting to have it be, led directly by the need of those on the front line. Really powerful. Kate, I'd love to turn and hear from you from your experience at your organization. How did you set priorities as well, and where are you going?
So I think, well, thank you, Rikki, and pleased to be here today. I would add to the conversation, we had very similar experiences to the other two speakers, and a lot of it was bringing that collaboration, bringing people together, quickly forming teams, engaging the staff or the people doing the work, whatever types of staff were engaged in that, and trying to come up with solutions that met their needs. And I think for us, that fit very well with our quality work that we were doing, and much of the our huddles, using our huddle process and kind of a go and see approach. So, going to where the work was done and seeing really what people were facing and trying to come up with solutions that would fit in that. So people weren't just in a conference room, or on a Zoom, trying to come up with a solution. And the final piece I would add is, I think long term, our strategy We were at a turning point just this last year. We've been working on a new 5-year strategic plan. And I would say for us, what's very different about it is while we still have come up with the categories or the main themes around that the strategy is organized around, we are taking a much more nimble approach and looking at tactics just at like 6 and 12 months and really trying to acknowledge that we need to be more agile, like little a agile, and nimble and responsive to what's going on in the market, what's coming up. There might be changing priorities, so trying not to stack everything out year 1, year 2, year 3 with a 5-year plan, but really being more flexible.
And that is, you know, perhaps if we really talk about probably a significant, that's probably very much so a significant change in mindset. If there's something that we've learned, I think it's that, and that we can make those confident decisions more rapidly. And now really kind of leads well into the next discussion topic that we want to discuss as a group is designing and implementing technology and bringing it into the patient care environment. It has its challenge, really, even in traditional times. You know, as nurse informaticists, we're often talking about how to best support the end user and how that translates to the benefits and patient safety down the line. So I would love to ask the group, how did you have to adapt during your initial response phases when you brought technology into the care environment? Did you find particular adaptations in your implementation process beneficial? Simply, what did you have to do differently, and how will you continue to incorporate those concepts? I think you started this a little bit actually in the first, in what we were just discussing, and being more nimble in decision making. Did that translate down to the end user experience for you in your implementation plans as well?
Yeah, I think that's a great segue there. Even the communication topic that people were talking about, we also had similar things there. And I think for us, I would say it led to iterations, right? Like we would try something and then we would get feedback, and then maybe we'd have another idea. We'd either iterate on it and improve that or try something different. So, you know, we had the baby monitors and all different types of handheld devices to help people with their communication. We ended up with some push-to-talk devices, and we tried so many different things. So I really just think iteration and listening to the feedback and where it was working, where it was not, and then where we could quickly adapt was something that took us through.
Which can be so much easier said than done completely. Nancy, I'd love to turn it to you, kind of sharing your experience. You know, how did you reach, as you made these decisions and you were bringing the new technologies into the care environment? How did you prepare nursing? They may have made the ask. You know, how did you prepare nursing to bring them into the environment, and has that, you know, changed your process from here on out in any way?
Absolutely. I think one of the biggest I also have the training team for the EMRs reports up through clinical informatics. And one of the biggest changes we had to make in preparation for the surge and over 1,500 flex staff that we brought in, as well as our ongoing onboarding, we had to convert basically almost overnight, within a week, to full virtual training. Originally, we were just trying to add devices to a room. And then when we got into social distancing and not being able to have these large number of people in the room, we converted from instructor-led training to fully virtual in about a week. And we had multiple classes going at the same time, and we didn't know how this was going to go. And we also had trainers who were very comfortable with instructor-led training. But, you know, a little bit on the agile that Kay mentions is, you know, we converted it to kind of what our classes were, and then we would rework it and rework those classes, because we quickly learned when you're teaching virtually, you need to adapt as well continuously and change what the content is. We were lucky enough to use a system that still allowed the staff to have kind of some hands-on play in our training database, which was very important to us, you know, at the time. And then after the initial surge, happy to say we did not go back. We continued with full virtual training. It is the way of the world now at Northwell. So everything remained fully virtual. And now we're starting to look at going forward what we did very emergently during the pandemic. How are we adapting that? How are we changing it? And, you know, continuing to evolve that onboarding of nurses and that training process.
Wow. And MaryAnn, I'm going to bring this question to you too. And while we know there's a lot of likeness between systems, I think the different nuances, and here while we're presenting with HIMSS, we're all looking to learn from each other, because obviously things are moving fast. Nancy, can I ask you just a next question on that? And in your virtual training, is it live in Zoom? Do you use videos? If you know, is there a specific format that you've implemented in that virtual training?
So we actually, it's a kind of a combination of your traditional lecture, you know, with a PowerPoint presentation that's done through WebEx. And the reason we do it through the WebEx system is WebEx has a component called Training Manager. So when you use the traditional WebEx format with this Training Manager layered on top of it, the Training Manager, we do still have classrooms, but we're looking on putting this in the cloud. But we have classrooms with devices there. And the trainers have a facilitator that during the session, when it gets to the hands-on, they can assign a device to each attendee, and that allows them to log in remotely to that device and practice in. And it's all managed through the Citrix training, WebEx Training Manager. So that's what allowed us to do things the way we always did. And now I have to say, honestly, we are reevaluating that, how we best, do they need that technical hands-on, or is some type of competency-based, you know, remote testing might be what we end up doing going forward. But that was the system that we used.
You know, we've talked about it time and time again here, just the complete pivots and how quickly they're happening, and you're already seeing results. It's quite inspiring. MaryAnn, I imagine there might be something similar, but tell us how things worked at MSK for you. Is this what's resonated? Did you find another answer to doing things differently when you implemented?
Sure. Many things are similar to Nancy and to Kay's experiences. I think education in general needed to move remote. Education needed to happen. And there were multiple levels of education along with systems education. To Nancy's point, we also converted nurses that were not ICU trained to become ICU level nurses remotely. And our nursing professional development department did a fantastic job. We use a shared governance model at MSK, and so we partnered, Nursing Informatics partnered with nursing education when it came to some of the educational modules, when it came to the systems pieces of it. One of the things that's come out of that experience, which again was fully remote for the training, was the ability now to really look at what the education is comprised of, and Nancy mentioned this, where part of the training is more, you know, it's more of what we might call lecture. We've moved that into more of a module level training with our nurse educators, really building out what that looks like, partnering with Nursing Informatics. And then the pieces that are more hands-on, looking at a virtual learning lab as the ability to really allow the clinicians. We didn't get to do this as nicely as we would have liked to during COVID. So that's why we were also on site monitoring what was happening in real time with the device, with all the technology. We couldn't leave it out there and not evaluate it. But now we have the opportunity to really partner with nursing education and our clinicians and do virtual learning lab. And we're looking at that as a more of a an educational way for all clinicians, not just nurses, to be able to go into this sort of playground that we talk about, to really be in a test environment and not, or a training environment, and not be out in production, and establish or learn how to work differently, because they had to learn to work differently. It wasn't just their training. Clinicians are now working differently. They're working remotely, virtual, telemedicine, as we know. So all of these things we learned from this, and we're incorporating in and continuing to build it. So along with learning modules that allow some of the competency pieces like testing to happen, along with the hands-on virtual learning lab with an educator and an informaticist in the virtual learning lab to really help see if there's questions and make sure people are know how to use the technology. So we've started to establish that, and we have actually some ideas and thoughts around how to move that forward to a larger implementation in the future. That does take a little more planning and strategic planning and financial involvement in that, but that's exactly what we're looking to do. As an educator, competencies to me, and especially informatics competencies, are very important. So I never want to take that away, that you can put everything in a module and just do an educational module and then you're good to go. We have to think about how workflow gets incorporated into these. So that's something that I'm remain very interested in as well.
That's really interesting. I think as technologists, we're, the training piece of it, kind of going back to the root of this question, is number one priority. We know that success has a direct relationship to how well you prepare whomever your end user is, clinician, not clinician, whether it's healthcare or not. But it's really interesting, your lab, I'm sitting here kind of putting all the pieces together, but that's really a pivotal shift, moving maybe from a device level or even just a singular use case level training, but more into broad workflow. And so really changing that element of practice. You're sort of opening up Pandora's box, and we're probably going to have a bigger conversation on that, but really exciting new way of thinking and a new way of supporting our clinicians. We're talking a lot about what do we have to do to reach people differently, and it's really no surprise it had to be that there was a root in it in transitioning to virtual and doing things where we can't reach one another. Another theme that we've that's coming up routinely is how do we connect? I think of that when we think of being virtual. It's come up in our conversation. So I think it's only natural to sort of pivot the conversation into virtual care. Virtual care has stood out as a pivotal workflow in enabling continuity in patient care delivery. It does encompass a wide range of use cases and workflows, and I imagine it may be different in prioritization between each of you, the different use cases. For the group, I'd love to know how has the increased incorporation of virtual care influenced both the patient and clinician experience? I think that's really important to discuss on both sides. And is that were virtual care, is it implemented inside or outside of the four walls at your organization? Nancy, could I ask you to go first on that one?
Yeah, sure. So I think my focus will be a little bit more on inside the four walls. During the initial, surge of the pandemic, we were using a multitude of devices for kind of, to me, a couple purposes. One purpose was for somewhat monitoring of the patient, because, we had units that weren't ICUs that now were ICUs, and, the structural build of the building may not have supported kind of that eyes on the patient. It was also for the isolation of these patients, because you heard over and over that they were in that room, and people were trying to minimize how much they had to go into rooms at times. And there was definitely that, for that patient experience, there was isolation on the patient's part. And then there was also communication, not only for the patient, but for the nurse in the room at the bedside who needed something with somebody outside of the room. And if you had to preserve PPE at the time, where you didn't want to have to gown up, mask, go in and out, and then come out again, and then go back in again, as well as to ease, just, for the timeliness of their care and being able to, support that patient. We used a combination of just tablets, random tablets, which would be, even a Samsung, one in the room and one outside for the nurse. We used echo shows where the patient had an echo show and there were echo shows outside. We also used another device that's called a Hello 2 device that allows you to watch multiple patients in multiple rooms and have this device outside the room. So it's kind of that virtual care just from within the patient room to outside of the patient room. As I said, we use so many different devices very quickly, kind of, probably the same thing for you guys, whatever you could get your hands on and whatever you could get delivered and get into the hands of the clinicians. And then we took that step back, as I said, with those work streams to reevaluate what was used, get the nurse's input across those array of devices, And then really identify for a going forward strategy. Yes, you need this during COVID, but could you apply these differently or use them differently to address other healthcare needs going forward? For instance, we all know we have constant observation patients. So we have, patients where we have a patient care aide or a PCA or a nurse's aide sitting in that room an entire shift. And a lot of times that's overtime because they've done a shift and now they're doing constant observation for the next shift. So if you develop the workflows and the processes, could you use a device such as a Hello 2 and have one PCA watching either 2 patients in one room or 6 patients in rooms that were located near each other? So we've started to evaluate and that Hello 2 was really identified as the best device that the nurses liked the best. It had, bi-direction audio, it had video, it also had night vision. So something you didn't get on some of the other tablets was so even at night, it allowed you to see that patient and watch them remotely.
It's really interesting. We know staffing challenges were an issue well before pandemic, and they're going to continue beyond. And that probably takes us a little farther in our dialogue. So I'm going to be conscious how far I go into that. But it's really exciting to see where virtual care, oftentimes we hear telehealth, people think outside of the 4 walls, but it's becoming mainstay inside the 4 walls and allowing people to reach one another in new, unique ways. And MaryAnn, we've talked about it a bit. Virtual care has enabled your clinicians to connect with their patients really in some, in a way that's transformed some very long-standing workflows. Can you share how virtual care was incorporated at your organization?
Sure. That immediately became evident. We have a very, very large outpatient environment, and our patients are across all 3 regions. And so the need to be able to communicate and keep track of the patients while, determining if they really needed the hands-on was important. So we were in the process of starting to begin telemedicine before COVID. I like to say we were sort of dipping our toe in it and figuring out how to do it. That quickly became, we need to do it. Everyone was the same. We all felt the same. We just didn't have the platforms in place to do it as well as we wanted to, because we just didn't, it wasn't set up that way. What we did put in place, and this was through a program that had already been started and evaluated. It had been called Insight Care, and it was a program to monitor patients who were higher risk for returning to the hospital, to see if there was a mechanism to monitor these patients post their treatment at home and pick up on high level symptoms that we could intervene sooner. So we had started a program such as that. That program became the program, and the people in that program became the people, along with a few other people, including my team, to look at how we could incorporate that into monitoring COVID positive cancer patients in the home, and to ensure that if they did begin to decline, we could intervene as quickly as possible. So that was through our portal and through daily symptom surveys. As soon as the patient was identified as a high-risk patient, positive, they received daily symptom surveys. They were interviewed by a nurse, an outpatient nurse, who explained the program to them and got them set up. And they were then the patient was able to respond to the surveys. We have a process in place that we built in our clinical system where the responses to the surveys, and again, this is already through a current program, but we just expand on the current technology. The nurses get an alert of what we determined was a severe symptom, certainly shortness of breath. Those types of things were the ones that we wanted to escalate. Between the nurse and the nurse practitioner, they would call the patient at the time, do whatever if we had telemedicine ability, or the patient had the ability, look at the patient as well, and determine if the patient needed to be brought in, to a local hospital or to the main hospital. We also discharged patients that had been COVID positive, but wanted to, again, we didn't know. I think we're all aware. We had no idea what it was going to look like when someone was sort of recovering from COVID and what that might look like when they went home. Could they decline quickly again? We just didn't know. We sent patients home, again, something that really required technology and a lot of testing very quickly to with pulse oximeters, and map those before the patient left, map that into our integration within our portal so that the patient would do a pulse ox and submit the result. And that would also be part of the data, then the symptom survey along with the remote monitoring. So it was a good test on remote patient monitoring, which we are learning quite a bit about the challenges and also the successes, but also the challenges. It's a great idea to monitor patients in the home, but there's much to be considered around the technology itself, the workflows, as we're all involved in, and then the response of what we do with that information when we receive it. So really interesting. The program has expanded into a larger program for our patients in general.
It's exciting to see always where you do that work, you do it quickly. Not only does it impact that immediate patient population and those who are tasked with caring for them, but then be able to carry it on into the future and expand it, as we incorporate more traditional patient care treatment plans. Kate, digital strategy was a main pillar of your long-term roadmap. Where have you seen virtual care as part of already? And then where are you guys going to take it? Where are you projecting it to grow?
Sure. Like many other organizations, we really saw an exponential growth in our telehealth use in the ambulatory environment. I see that sustaining. We had a really high, mid-90s% of patient satisfaction with that approach. And I think people are really clamoring for, yes, there's times it's appropriate to come in for a visit, but there's lots of times where a remote visit really meets their needs. And I think in some care specialties, take behavioral health, I think there's even a higher preference for not having, stigma that might be associated with going in to a building or an office and liking that ability to maintain that remote contact. We did some similar things around an enhanced home care program for COVID positive patients and some remote monitoring. We did some things there. We did a pilot with a hospital at home program, and really now, and even as recently as a couple of weeks ago, we implemented for our home care and hospice staff use a different EMR at this time. We're still looking to get them onto our main EMR. And we had, with the gas pipeline issues, we had issues with home visits. So we implemented a virtual visit solution for them using Doximity and just letting them have that as an option. Obviously there's sometimes they needed to go in the home if they're doing physical care, say wound care, but there were many other times when a remote visit that or maybe the second visit that week could be remote and that could be supported. So as far as looking ahead, I think there's additional things in our future around digital care and specific around virtual for nursing. We're looking at things that we do today via, say, telephone, where we do a pre-op screening call or a post-op follow-up call, a post-ED visit call, any of those kinds of things, adding in the video component to increase what we can assess with the patient, as well as looking at, say, nurse triage. I think the triage nurses are probably clamoring the most of if somebody's calling in and has an issue, if I really could see them, I think that would really help in addition to the questions that I asked to, follow an algorithm and triage them to the appropriate place. That would just give me that much more to influence the decision and the outcome for the patient. So those are some of the things that we're looking at.
Well, as all things will have it, I think you had noticed that the show goes on and I've lost my Wi-Fi, but I am back with it. And so I apologize, I've just cut the tail end there. But thank you for your response. I'm glad I was able to join again quickly. looking at our time and just sharing what we've discussed here today, I think it's fitting that as we continue to celebrate the extension of the Year of the Nurse that has started in extended here into 2022, and even more pointedly in May, which was we continue to celebrate Nurses Month. Much of what we've talked about has been all about spearheading innovative ways to support our end users, and in this case, time and time again, it was how do we support our clinicians? As we look ahead for the nursing workforce, we know it's facing challenges, whether it's with shortages or adaptation. I'd like to ask each of you as an individual who is both a technologist and a clinician, how can we as technologists and clinicians can better work together moving forward as we fill the gaps in our workforce where technology will play a role? I think there might be some to trends that we've discussed in that today, but this is kind of a chance for a crystal ball. What's next with technology and where is it going? Where can we be even more innovative than we've had to advance some patient care models? With that, MaryAnn, I think whether from your experience in academia, leading the next generation of nurse informaticists, or in practice, can I ask you to share your thoughts?
Sure, absolutely. The reason I believe so much and the reason I teach is because I believe so much in this role of nursing, of course, and informatics together and combined to ensure that clinicians, nurses, have the technology tools to support the care they deliver. You know, many years, many clinicians, nurses included, relied on their critical thinking to be able to care for the patients. We have a lot of technology today, and building the artificial intelligence tools to really be for nurses to trust them and to be used as part of the care delivery model, I believe is the future for nursing. And I think our future nurses will be looking for those types of technology because they've grown up with technology. They rely on technology. And for our patients, it's important that we do not, and this is something I'm very, very interested in my future research, is to not lose the patient-centered care piece of what nurses bring to the patient, but be able to use technology to continue to have and expand on the patient-centeredness. And I believe it's possible that patients will still respond to the nurse virtually as they do in person, but it's a very, very key part of caring as nurses, as well as the other medical and the science that we bring to the table to ensure we care for patients appropriately. It's a piece of that. So that to me are really important aspects of care delivery in the future. Virtual care is absolutely here and it's not going away. How we improve the technology to trust it, because I think that's a large part of moving the technology as quickly as we all did. It's definitely something that if we took more time, but again, try not to take the time, but to be smart about this and to move it forward. And the technology can support that today. Years and years ago, technology was not as agile either. Neither were we, but neither was technology. So those are some of my thoughts.
That's a great way to look at it. I appreciate kind of the chuckle. Nancy, with your extensive experience in informatics as well, and even circling back to the start of our conversation, the one question you asked your clinicians, what do you need? I'm just stuck on that. I think it's just a really powerful way to drive a strategy. What is your advice for how clinicians and technologists can better work together in solution design?
So of course I'm going to say, a little bit of echo. Of course I'm going to say that at the foremost and at the forefront, we always say everything we do in informatics and as nurses ourselves is involve the bedside hands-on caregivers, whether that is the nurse, whether that's the physician, whether it's allied health professionals, it's always to involve them. I tie it back to, you know, we jokingly say, thank you, COVID, for our progression on our mobile devices, because we actually did probably about a year ago, we had a device fair for mobile devices, and we got the CNOs to send nurses to our central innovation center, and they evaluated, because we weren't going to pick the device for the nurses. We wanted to pick them to pick the device. So they had picked the device, and we were working towards a rollout plan, which after the executives of the health system heard what did nursing need, and when they said they needed a mobile device, we've now rolled out across 3 of our tertiary facilities already since March with mobile devices. What has immediately come back to, and this is that forward looking, is we started small with our EMR app, with some Teams for communication, and with a Northwell app. Immediately, nurses started thinking, as they will, how to solve things, that they don't want the rest of this tool belt they're wearing. They don't want what about an app for this? Whether there's an app or not, I think nurses are going to design it. And if there are apps out there that we're already using, how do we add them to this mobile phone? But we don't want a mobile phone with 50 apps on it that they then have to go to this app, go to that app, go to this, go to the other one. So we are, we're creating a governance process, looking forward for how do we bring in new apps smartly to support them, but not overload them. But we're also pushing back on the apps folks to say these kind of need to be integrated. The more we can integrate them, and then you log into one thing and everything, kind of works together. Alarming, as we've talked about, video monitoring. So that's kind of, but at the forefront of that is we're now creating a mobile app lab in our innovation center, so that when these things come in, we can once again pull the end users in and get them to evaluate and say, oh, forget that. I can see some of my nursing colleagues from back in the day. I don't know why we got this. Forget that. It's not even going to work. I don't know who brought this here or who thought about it. So, we just really, we have to include them, and they're gonna guide us, and they're gonna identify what works for them.
Absolutely. Can't help but chuckle at it. And, we're in a HIMSS webinar. All of us are technologists. All of us have supported a go live, and that phrase of who did this is exactly what we're trying to avoid. So how do we start at the beginning and make sure we do it right the first time? Kay, you said it earlier on in your processes, you started with where the work was done. And exactly. It all lines up. Can I ask you, if you're looking in the crystal ball, where technology is going, how is it better connecting clinicians, or what's your crystal ball on how we're going to work better together as in the future?
I think I'll reiterate some of the same things. I think, and some of what I said earlier about engaging the users. I think going and seeing their environment, their work, their collaboration, and I think engaging the end user regardless of the role, and also having a multidisciplinary or an interdisciplinary group doing the work is really key, to kind of bringing all the players to the table, and like where are those handoffs, whether it's communication or in their clinical workflow, and how might we improve on those. I also will comment on what MaryAnn said about AI and artificial intelligence. I think that's really front and center and coming our way. And I think we need to, again, engage those clinicians and other users in where should it automate their work? Where is it a support as far as clinical decision making? And better yet, where does it fit in their workflow? And how do they want to be presented with it? And what do they do with it? At Duke, we have an incredible amount of resources to help on the AI front, and we have people developing machine learning models, deep learning models. And for me, it's about supporting the clinician and where does it make sense for them to get it in their workflow, and is it in their EHR so they don't have to go somewhere else, that we just embed it with what they're doing. And I think the other piece I would add is I would really like to see more nurse-led innovation in general. And I had the privilege a couple of weekends ago to be a panelist for a hackathon, and I really think that nursing has lots of great ideas, and how do we get people to say, this is my problem, and then how do we work as a team to come up with a solution that would support improving that care delivery efficiency for the team. So
Absolutely. I think nurses leading the way, and there's a piece there where it's no surprise. We're all going to agree on nurses leading the way. I think what's exciting is something that's happening here too, is nurses from whether it's different health systems or different regions sharing that experience together. So, and that's going to be extremely powerful. And if there's something that the last years have taught us is that sharing information, sharing data makes us all better. And with that, I want to thank each of you again for contributing to this just absolutely energizing dialogue here today. We intentionally wanted to leave some time if there were questions from the audience. And so, Tony, I don't know if you want to come back and join us and help with the Q&A.
Sure, I'd be more than happy to help. I think Lonnie has been monitoring that, so I'll ask Lonnie to see if he can contribute to any good questions that he saw coming up that haven't been answered so far.
I haven't seen anything in the chat.
Okay.
One question, and I think it came up, we've talked about making change and looking back, and we'll wrap after this, but if you guys will indulge me in one more question. It's very informatics focused. As I was preparing for this, I thought it would be beneficial, given our audience here, if you have any thoughts, what metrics are you using to measure the impact of the prioritized implementations? Are those different now than perhaps they were either at the initial onset or at the immediate pandemic response? I think we talked a little bit that, kind of did what you had to, and then you step back. But now that we're moving perhaps more into a normal cadence with agility and a lot faster than we have in the past, how are you monitoring? How are you measuring success? And I might open that to the floor if someone wanted to jump in here.
So, hey, I'll jump in there for a second. So, it's really hard with a lot of initiatives that you put out there, technologies, systems with nursing, we're asked to constantly look for an ROI or a monetary success that we can measure. But a lot of the time it's a time savings measure. It's a time study or emotion study. It is a quality of care, or it is a quality of nurses' daily life. It's really subjective what that is. So I will say, we always struggle with how do we measure this, but as we're rolling out mobile, we try not to let go of that subjective, because we do want that feedback from the nurses, because that goes a long way when people hear nurse satisfaction, staff satisfaction with something. One of our sites got the mobile devices rolled out during Nurses Week. So their CNO joked around saying, I got you phones for Nurses Week. You're not getting, a bag or another gift. But it does go a long way, that satisfaction. And then we do actually measure some compliance numbers to barcoding and noticed increased percentages. But I think this is it is a definite struggle when you're rolling things out, particularly in nursing, that how do you measure it? And I know we constantly do try to identify ways and share feedback, but it is a hard thing for us to measure.
Thank you, Nancy. MaryAnn or Kay, thoughts, similar sentiment?
I'll go ahead, Kay, if you, yes, number one, I think Nancy hit the nail on the head. Many things we strategized in the past might be along with certainly a strategic vision of where we might want to be. Quite a few things we look at from a quality perspective as well. I'll share, and I mentioned earlier, whenever we're putting any technology in place, we're a magnet organization and we use a shared governance model. And one of the things I learned very early in my career in informatics was, yes, we can do it, but should we do it? And the other piece is it really the problem? Because the technology is a great enabler, but it may not solve the problem that the users are feeling they have. So much of what we do as nursing informaticists and nursing informaticians is to understand really what they're doing today and map that out and understand the current state, and then look to the technology to say what really is the problem before we turn to a technology solution. So the technology is smarter, and based on that, we usually end up with those gaps that we can then say, okay, this is how we improved what you were actually looking to do. So I would say, and we look to define the practice. And in some cases, there isn't an evidence-based practice. And that's also part of this, that we may need to do research in the future to develop evidence-based practice around the future way of how we're working and how we're delivering care. But we do our best to also ensure standardization of practice. And I know we're running out of time, so I'll let Kay go.
Yeah, I would add, I think in some ways, many of the metrics are the same, things like patient satisfaction that we evaluated with telehealth, or staff satisfaction that's been mentioned. We align a lot of things with the outcomes quality programs, so things we're focusing on like falls or pressure injuries, for example. And I would say that I think the newest thing that we've really focused on lately has been efficiency for the staff. And is there a time savings? Are the changes that we're implementing going to be more efficient and not something that's really going to take more time for their documentation, for example?
Rikki, we got a question that came in from the audience here. And the question is, as you added a lot of devices during the surge, particularly video, were there performance issues with the Wi-Fi infrastructure, or did it take the extra load? Interesting question, huh?
So I could take a stab on that one. You know, we have many different facilities in Northwell, so it all depending on the facility and the age of that infrastructure. The majority of our facilities were able to handle that addition, the Wi-Fi and the video. But we actually partnered closely on cross teams developing these surge areas and adding the devices. So right beside us, I call them my tech buddies. There were, you know, I'm the nurse, but there were my tech guys, you know, so that when we did come up on that, we were able to pull them in, do quick Wi-Fi evaluations, and then hopefully add additional WABs and, you know, access points as needed. But the majority of them, it did not, because it wasn't continuous ongoing video nonstop, or, you know, it was intermittent use, we didn't see too many issues with that.
Excellent. Anybody else have any comments they'd like to make on that one?
Yeah, I could say that we also did not, we had already been in this environment of mobility and mobile devices, and a lot of that work had been done, especially the dead zones in the infrastructure of the hospital, to Nancy's point. So a lot of that was already in place. To also to Nancy's point, though, our Friends of Nursing, our field service team, and they partnered and were right at our side, along with our medical engineers, who were fantastic in ensuring some of the technology that needed to be updated, like our blood pressure machines that we turned to a Wi-Fi solution in order to pull data, were turned on quickly, and we could test right in production, which again is not my way of doing things, but was something we did during COVID. So yeah, we had a lot of support, amazing support.
There's another question that came in. During the COVID situation, you were forced to accelerate certain things in your organization. Did you find anything that you accelerated that in the past took a lot longer, and now you realize that it doesn't need to take that long to, whether it's implementation, acceptance of a device, something like that?
Okay, that looked like that resonated with you. Not
Well, I chuckle. I mean, the whole notion of having a COVID command center and like we need this problem solved today or tomorrow, and bringing the people together. So I think part of it was everyone's focused effort. And I would say for my organization, I think what's resonated is having priorities and everyone agreeing on the priorities. Like, this is the most important thing. We all need to work on this now and together, is probably the best thing for facilitating that quick efficiency to have a project, come up with a solution and implement something and iterate on it. So I think aligning long-term, aligning the priorities in the organization is probably most beneficial to continuing that kind of quick and efficient implementation.
Excellent. Well, Rikki, any final comments you'd like to before we close the hour off?
Well, I once again will thank everyone for taking the time to join us. I want to thank the panelists for what you shared. Walk away here today with so many just really thought-provoking concepts and experiences to learn and share from. At the root of it, I think stood out to me time and time again on each topic we discussed was about working together. Clinicians, technologists, MaryAnn, you exemplified in just the question before last and all the many roles that are involved in healthcare and patient care delivery. And if we continue to work together, share experience, share lessons that we learned, we're going to continue to support all our really wonderful colleagues on the front lines who are making a difference every day. So thanks everyone for joining us here today, and thank you, New York HIMSS, for hosting today's event.
Fantastic. I'd like to just close everything off by saying thank you to everybody. It was another great session. And folks that are out there, please register to vote for our upcoming elections. We've got some people that are really looking forward to, being part of our board. And anybody else that is interested in being part of our committees, please take a moment, send information out. My email address is anthony.ferrante@nyshimschapter.org. Feel free to send me a message. I'll be more than happy to direct you to the right people. And look for our next events. We have a couple coming up in June. Don't hesitate to come up with any ideas. We'd be more than happy to share them with everybody. And again, come and join us for our next events. Thank you all, and have a good day. And hug a veteran, because we got Memorial Day weekend coming up, and thank them so that we're able to do things such as this nature. Thank you again, everyone. Signing off.